Hi, I'm Laura Thompson, and this is my review of magnesium sulfate on preeclampsia. A little bit about me. I am a nutrition student in the master's program at University of New England. I am a mom of 3, and I had preeclampsia with 2 of my pregnancies. So this topic is pretty important to me. A little overview about what we'll talk about. I am going to go through a background of my research question, how I selected my articles. We're going to discuss those articles, compare the results, conclude and grade those articles, talk about some of the strengths and limitations, and then how those articles, what they imply for future research and for future practice. So a background on preeclampsia. Of course, preeclampsia is known for its high blood pressure in pregnant women, swelling of the hands, face, or ankles, protein in the urine, headaches. There's other complications as well. And then there's also complications in baby as well. For the purpose of this review, I did not even look at the complications of baby, but there are those complications. And then preeclampsia can lead to eclampsia, which is going to be that brain swelling, the seizure activity, which is what eclampsia is known for, and then it can even cause death. Preeclampsia does occur in about 5 to 8% of pregnancies. It can be as low as 2% in some countries and as high as 18% in other countries. So it is pretty relevant. Worldwide, there's about 140 million pregnancies a year. And then roughly, so 5 to 8% of that, roughly about 10 million pregnancies moms will get preeclampsia. Now, eclampsia usually follows preeclampsia, but it can happen anytime and without warning. So really, you're actually looking not just at those 10 million, but at the 140 million. So it is a very relevant topic. So magnesium, of course, is a nutrient that regulates blood pressure, energy production, and stress response in the body. Magnesium sulfate specifically is used to reduce the seizure risk in those women with preeclampsia. It does improve blood supply to the brain, so it's basically stopping that seizure activity. The current standard in most hospitals is going to be a low dose, usually about 46 grams, and then 1 to 2 grams an hour for up to 24 hours. So you're looking at a minimum of about 30 grams within that 24 hours. So that's a lot of magnesium in a very short amount of time. So there is a risk of magnesium toxicity. I did list the side effects there on the side. You can read them. So you are helping with that seizure activity, but there's a chance to get some other side effects as well. So my research question becomes, is it possible to lower the magnesium dose and still have it be effective? And so my research question is, among pregnant women ages 20 to 45 that are hospitalized with preeclampsia complications, how does taking a magnesium sulfate supplement of between 16 to 30 grams, so I'm trying to get under that 30 grams, impact magnesium serum levels and eclamptic seizure activity in 24 hours? So when I was looking for studies, I did really want to try to include randomized control trials. I did look at other studies, of course, but I really wanted the gold standard of those controlled trials. I didn't want anything older than 10 years, preferred less than 5 years old. Of course, they needed to have pregnant women with preeclampsia, gestation over 20 weeks, women between the ages of 20 to 45 years old. I really wasn't looking to do teen pregnancies for this specific review, and they needed to have at least 10 participants in each group. Keywords I searched were magnesium, preeclampsia, eclampsia, pregnant women and seizures, high-risk pregnancies, a bunch of variations of those keywords there. Those weren't the exhaustive words, but variations of those. And then databases I used were Cochrane, PubMed, and Embase. I excluded criteria For instance, they didn't meet the age requirement, the study was too old, the study design was not what I wanted, didn't measure the correct component. I did find a study that measured like zinc and preeclamptic seizures, and so of course I excluded that because it wasn't the right nutrient. And then I found another study that measured cardiovascular activity and preeclampsia in women, and so I excluded that study because, of course, it wasn't measuring seizure activity. I did exclude anything that wasn't in the hospital setting, and then the dosage didn't fit the criteria I was looking for. So methodology, I did find about 300 different studies originally when I looked at those 3 databases. After like looking at the duplicates, there was a lot of reviews of those studies. So like reviews of the studies or duplications of those studies. Once I took all that out, it really kind of whittled down to about 37 studies. I did screen about 37, excluded 27 of them. And then fully read the 10 articles. I excluded 4 more, again, for those reasons I cited. And then I ended up with 6 studies, or 6 articles in my review. So let's get into the different articles. The first one had a population group, 31 in the experimental group, 31 in the control group. They were all given a low dose of 6 grams. Each of these studies were all given a low dose first. And then the experimental group was given 2 grams an hour for 24 hours, and the control group was just given 1 gram an hour for 24 hours. The results did show that serum magnesium levels were higher in the group that got more magnesium, of course. No cases of eclampsia occurred in either group, and side effects were fairly similar in both groups. They did conclude that the lower dose group, so that 30-gram group, was just as effective as the intervention group that had 54 grams, with fewer side effects and less risk of toxicity. Their limitations were that this study had a small sample size. Seizure activity wasn't necessarily the first thing that they measured, but they did measure it and they did report and discuss it in their findings. So I did include this in my studies. The second study was interesting. It was the smallest of all the studies, so it only had 18 in one group and 19 in the other. This study was interesting, though, because it very specifically measured women who had a BMI over 35. So the experimental group was given a low dose of 4 grams and then 1 gram an hour for 24 hours. And the control group was given a low dose of 6 grams and then 2 grams an hour for 24 hours. Again, the results showed that magnesium levels were higher in that group that got more magnesium. Side effects were more common in the control group. Nausea was the biggest side effect. And then only 5 patients in the control group, so the one that got the most magnesium, only 5 of those women achieved what's considered therapeutic levels currently. So that's really interesting, and that's going to be something that we talk about when we get to how this affects future implications. So this study again did conclude that the lower dose was just as effective as the higher dose, and it had fewer side effects and less risk of toxicity. This limitation was this one. Again, it was a very small sample size. This one was also not a blinded study, which could skew results. And it did not measure, all the other studies recorded mean age and then gestation week as well. This one was very specific that they had to be over 32 weeks gestation, but did not actually report any of the measurings that they had. And then the sample was not based on the whole population. It was only those women with that higher BMI. The third study had 76 in the first group and then 43 in the second group. So already we can see a limitation there. They were not very equal groups. However, the demographics in both groups were very similar. They were given a low dose of 4 grams, and then Group A was given 1 gram an hour for 6 hours postpartum. Group B was given 1 gram an hour 24 hours after postpartum. So it wasn't necessarily 6 hours total or 24 hours total. It was up until 6 hours postpartum. So they ended up getting a mean dose of about 15 grams or a mean dose of about 42 grams in the Group B. So no seizures occurred in either group. And then group A had reduced side effects, reduced need for long-term monitoring, and reduced toxicity levels. So they did conclude that that shorter course and lower dose was just as effective as the higher dose. The limitations, of course, we said unequal sample size, and then this was also not a blinded study as well. Okay. And then, so the fourth study had 79 in the experimental group. The control group had 91. The load dose was the highest load dose I've seen in actually all the studies I've read on this. They had 14 grams given to them up front. And then the experimental group got 5 grams every 4 hours for 12 hours. And then the control group got 5 grams every 4 hours for 24 hours. So the results did show that one woman in the experimental group did develop eclampsia, and she was continued with that 24-hour intervention. She was fine by the end of the study, but she did need that longer dose. And then side effects were pretty similar in both groups. There was less pain at the injection site because obviously the experimental group is not getting a shot for as long. So they did conclude, even with that one woman, 78 had no eclamptic history there, so they did conclude that that 12-hour dosage was just as effective as the 24-hour dosage, and it had less toxicity risk as well. The limitations of this study was that it was not a blinded study, which could skew the results. Excuse me, this study was my favorite of all the studies. I thought the study was really, really well done. This study was also interesting because it had 3 groups instead of just the 2. So it had a group A, B, and C. They were all equal in number, 80 in each group, very similar demographics. Group A was given a low dose of 6 grams and then nothing else. So just the low dose, they were given a placebo the rest of the time. Group B was given a low dose of 6 grams and then 12 grams in 12 hours. And then group C was given a low dose of 6 grams and then 24 grams in 24 hours. So there were no incidences of eclamptic seizures in any of the groups, and then side effects were, of course, higher in that higher dose magnesium group. By quite a bit, actually, very significant. The conclusion was, hey, maybe we just need a single load dose. Maybe we don't even need the short dose or the full dose, but the single load dose and the short dose were just as effective as the full dose. I really didn't see very many limitations with this study. Maybe it could be considered a small sample size because they're, in comparative to other studies out there. But other than that, it was just a really well done study. And then the last study had 40 in each group, very similar demographics. They were given a low dose of 4 grams, and then the experimental group was given 1 gram an hour for 12 hours, and then the control group was given 1 gram an hour for the 24 hours. Again, results, side effects were slightly higher in that control group, and there was no eclamptic seizures in either group. So they, of course, again, concluded that a lower dose or time frame was just as effective as the higher dose. And then the limitations in this one, again, a smaller sample size. Now, this one was interesting because the ages of the women were not comparable. So in the experimental group, 75% of the women were between ages of 30 and 40 years old, but in the control group, only 37% of those women were between the ages of 30 and 40 years old. So that does lead me to question whether age has to do, like, is there a sweet spot where a specific magnesium low dose or level is more effective within that age group or less effective in a different age group. So that's something to consider as well. This is just kind of a comparison of all the studies, a very quick comparison. All of them were given that low dose, and then they're either or on kind of their interventions. We're going to go over some more comparisons here. So all of the studies, all 6 studies used a low dose between that 4 and 14 grams. All 6 studies used a 24-hour time frame as one of their interventions, and all studies were the randomized control trials. All studies used similar demographics, pre-eclamptic women. They had very specific inclusion and exclusion criteria for who they were using in their studies. Some of the differences of the studies were that 3 studies were blinded, so that could skew things. One study did specifically look at that BMI, that higher BMI level. And then one study had a woman that, of all the studies, only one woman had eclamptic seizures. 3 studies tested for 12 hours versus 24 hours. And then 2 of the studies tested for 1 gram versus 2 grams in 24 hours. So the outcome of all the studies combined is that there really is kind of a sweet spot of 16 to 18 grams was most effective, with the least amount of side effects, the least amount of toxicity. So that would basically equal out to a low dose of 4 to 6 grams and then 1 gram an hour for 12 hours. So, and then increased magnesium serum levels did not have an effect on seizure activity at all. So as we're looking at conclusions from all these studies, a lower dose of magnesium sulfate between that 16 and 30 grams in 6 to 12 hours is sufficient in raising magnesium serum levels enough to prevent eclamptic seizures, while also minimizing the side effects of toxicity, the side effects, and still treating those eclamptic seizures. The lowest dose in the shortest time frame should be used. All the studies kind of concluded that that was what was best for each situation. And of course, unless the woman is still experiencing further complications, and then of course she should follow that longer dose intervention. So I did grade this as a 2 for fair. I think a lot of the studies had like really, really good information, and we're going to go over those strengths that the studies had. But there was still questions that I had when I'm reading through them, and that criteria of what I'm looking for in those studies when I'm reviewing them. So I did give it a 2 for fair. So strengths of the excuse me, strengths of the studies is that the design of the studies were all the same, very similar, gold standards, those randomized control trials, similar population, demographics. It's very current and relevant research. 140 million babies a year is very relevant. Studies were easily monitored. Interventions were all very similar in design. They were in a hospital setting. They all had the similar different dosages in there. And then what I really loved about these studies is that the inclusion and exclusion criteria were very clearly stated in the studies for not only who they took as participants, but also what they defined as preeclampsia and what they were specifically going to include with those women. Now, limitations were, again, that small sample size. Not all the studies were blinded. There wasn't really a specific dose that was defined in any of these studies. Like, this is kind of my mean, like my conclusion is on the mean of all those studies. And then there was no control for other factors during the rest of the pregnancy. So implications for future research and practice. What other conditions need to be considered in these women? Of course, blood pressure is a huge part of preeclampsia, and I didn't even touch on that. Most of the research did have that information, but it wasn't relevant to my specific research question. But it may be relevant to magnesium levels in the future, so that might be something to consider for other research. Age, like I said, that one study, is there kind of a sweet spot for where different serum levels work better? Other medical conditions like diabetes or something like that, gestational diabetes, how does that factor into that magnesium serum level? And then again, that BMI, the one study looked at that BMI specifically in those higher BMIs, but I would love to see a study that looks at all BMIs and then does that and impact them. It doesn't seem to. All of the studies besides the one woman, all of the studies the lower dose worked, so it didn't seem to, but it's something to consider. And then so in practice, we know that magnesium serum levels do not need to be as high as they previously thought to be therapeutic. Right now it's, I think, 1.8 to 4, I believe, and the higher, of course, it goes, the more you're going to have those toxicity levels. So if we don't need it to be that high, what should our new therapeutic level be? What should the new standard be in the hospitals when we put this into practice? Again, in that practice, there's a benefit of using lower dosage at the minimum hours. There's less side effects, less toxicity levels, but it's still effective for those seizures. And so that is basically my study. So I hope you enjoyed it, and thank you for watching.